Can I ask that everybody, kind of shut off their electronics, phones, make sure everything's on silent, put away. You don't have any distractions. So it's my pleasure today to introduce Dr. Tony Suchman. Tony is a physician, organizational consultant, and professor of medicine at the University of Rochester School of Medicine and Dentistry. He comes to us, he's here today and tomorrow as a visiting scholar in the Health Thought Leadership Network, and we're just thrilled to have him. Tony's work focuses on organizational change and how people can work together more effectively kind of across all levels of healthcare. So he's the founder really of relationship-centered healthcare, and he's pioneered aspects of relational coordination, which you might know from your management classes, in improving team performance and work environments. Tony's most recent book, Leading Change in Healthcare, Transforming Organizations Using Complexity, Positive Psychology, and Relationship-Centered Care, was published in 2011. And he really thinks about the organization as a conversation and the relational aspects of organizations to try to improve patient care. I know Tony's work, as some of you know from my classes, studied patient-provider communication, and Tony has had an extensive career, more than 95 articles and book chapters. We won't make you read them all for class. Studying patient-physician relationships, medical decision-making, physician satisfaction, mindfulness, and the spiritual aspects of medical care. And Tony's here today because at Bentley we talk a lot about fusion and the fusion between the arts and sciences and business. And Tony really is an interdisciplinary or fusion scholar. His work combines principles and practices from medicine, psychology, management, systems theory, communication, to address the complexity of the healthcare system and ultimately try to improve the relationship-centered care for patients. So without further ado, Tony, thank you so much for being here. This evening, if you'd like a chance to kind of interact with Dr. Suchman and some others in this area, we have a reception in Damien from 6 to 8 p.m. tonight. So if you're interested, if you could just kind of touch base with me after and let me know if you plan to attend, but you're all welcome.
Thank you. Some parts of that description actually sounded a little familiar, so I'll do my best to live up to that wonderful description today. So I'm very excited to be with you. I'm very excited about Bentley and what I've been learning about your program. I'll have more to say about that a little later, I hope. And very honored to be invited to be a visiting scholar with you today. Already enjoying the conversations that I'm having with some of the faculty, and I look forward to a lot more. So here we are, right at this moment. We're in a session where we're talking about interdependence, right? So it seems important that we try to make the medium, make the format match the message. So it wouldn't be very interdependent if I just stood here and talked for a long time and then passed the microphone back to you for questions. So I really want to see what can we do within the constraint of the number of people involved here to make this an intimate and co-created conversation. So what I thought I might do, following this theoretical framework of relational coordination that we'll talk about a little bit later, and we're actually privileged to have the author of relational coordination, Jody Hoffer-Guttell, from across town at Brandeis here with us. So more to come on that. But two of the principles of relational coordination about what it helps to help people work together interdependently are shared goals and mutual respect. So I wanted to just check in with that right at the beginning by telling you some of what my goals are for this session and what I need from you, what I would ask of you. And then I want to hear something about your goals and what you ask of me, as best we can do that dialogue under these circumstances. So here's what I'm hoping, and I hope this will have something to do with what your goals for this session. We're going to find out in a moment. First of all, to foster some excitement and some new thoughts about systemness, about what it takes for people to work together effectively so that the individual parts add up to something greater, that the whole is greater than the sum of the parts. So some thoughts about systemness and what it takes to make that work, including some research based, some of Jody's research. Then I want to take a look at healthcare, what's happening in all this tumultuous time for healthcare right now, and to try to make sense of some of that, looking through the lens of systemness and the effort to try to form into systems when we have never been before. And then finally to think about implications for management, since that's something that I know a lot of you are thinking about how to be effective managers. And what does management mean in a context of systemness? It's very different than where a lot of management theory comes from. So those are my goals. And then if we're going to work interdependently to co-create this session, some of the things that I would ask of you are to try to honor these operating principles as best as possible. So being present, participating as fully as possible, and yet paradoxically linked to that is for you to decide how you want to participate. So I may invite you to do some things, and you may decide whether you want to do that or not. You're in charge of that. It's completely up to you. I respect your autonomy and your ability to decide for yourself what's best. But within the confines of that, as much as you're willing to do, that would be great. To say what you're thinking, respectfully, and to be curious about what others are thinking. To value and explore difference as our most valuable natural resource. The differences in this room, we will learn a lot more and be much more resourceful from those differences than we are from the sameness, the similarities. And finally, to observe confidentiality. If someone says something here, before going off and saying what someone else, telling that to someone else, ask them if it's okay to do that. So those are some operating principles. That's what I would ask of you. So here's your part. I want to ask, in terms of your goals, what drew you to this seminar? It could be that it was required. It could be that you've got an interview coming up and you hope maybe you could learn something useful. I don't know what it is, but whatever drew you here, what you're hoping to learn, and then anything else you want to say about what you need from me in this reciprocal interdependence. I'm going to ask you to do this in an incredibly efficient way. Sometimes there's this paradoxical term of enabling constraints. So here's an enabling constraint. If you find someone to partner up with, one person, and then in the pair, each of you takes a minute, 1 minute, it's very quick, to answer these questions. That minute sort of forces you to get right to the point. So huddle with each other for a minute, then we'll come back and hear some of your thoughts, and I will, as many as we have time for, and then I will try to be guided by those and integrate your goals with mine. Okay? So find a partner, take a minute each, or 2 minutes altogether to answer these questions. So 1 minute is actually up. 1 minute is up, so switch and the other partner talk if you haven't had a chance to talk yet. We'll come back again in another minute. Okay, let me interrupt these conversations and invite you all back. Oh, you're so good. Thank you. Thank you. So now, asking you, speaking in single sentences and not paragraphs, let's start with these first two questions about what would make this valuable here. What drew you here? What are you hoping to gain from it? Can we hear a few answers? I will be annoyingly patient. Yes.
I'm coming from my bio class, and so it's kind of what I've learned, and also about the investment in healthcare. So it'd be interesting to see what we learn from this seminar.
Great. Thank you. Who else? Thanks for getting us started. Yes.
It's actually required to come for class, but looking to
Great, great. I think there will be something here for your group, and we'll talk specifically about the medical record a little bit, what's being asked of it. Who else? Yes.
The link between healthcare and management, because business really has to do with everything. So I'm just looking for the link between the two.
Cool. That's what today will definitely be about. That's good. Anybody in the back? I don't know if I'm just nearsighted or only the people in the front are raising their hands.
I'd love to hear you talk about Trump's health.
We'll have to meet afterwards for that, because I can't do that without getting too mad, and then I'm going to be off my target. But it's an important topic. But this is sort of larger than just what the current policy has to be. Although maybe there will be some implications. Let's see where it goes. But I'm glad to know your interest, and sorry if I disappoint you. Anybody else? Yeah.
I'm generally interested in patient outcomes, and I'd like to learn about barriers that patients face.
Patient outcomes and barriers. So this will be about what's happening backstage that has everything to do with what patients are experiencing, how well we can meet their needs. It won't be, well, let's see where that goes too. You never know what's going to emerge. That's what I like about this. Okay, one more? Or how about the other question in terms of what do you need from me for you to be an effective member of this seminar? Hopefully you can hear me speak. The amplification is adequate and I'm speaking clearly enough. But anything beyond that? Hopefully I know what I'm talking about, but you'll be the judge of that when we finish. Okay. Okay, good. Let's go on then, and let's begin by talking about systemness. What do I mean by this word systemness? You probably know already. Here's a figure. This is a relational map, and again, this is a method that Jody invented. You've seen organizational charts, those kinds of trees of authority and the distribution of decision rights and for distributing systems of accountability. And you've probably seen work process maps, flow charts of a process, or value stream mapping, things like that. This is a different way of looking at a work process. In this case, this is a dental office. And this office is owned by a larger dental practice management company. So you have the dentist, you have the dental assistant, the hygienist, the practice manager, the people who work at the front desk, and then people from the company who provide expert resources in areas of HR, finance, accounting, facilities, things like that. So this is a relational map. So these are, in this case, sometimes these are individuals. Could be a small practice and there's only one dentist. Sometimes these could be work groups where there's a number of people in each of these different roles. Sometimes on a relational map, it could even be different organizations that are working together, say to form an accountable care organization or some other alliance for some community benefit. So it's a map of the relationships. And so you have each of these different work groups or individuals or a mix thereof. And then there's a kind of a relationship between each of the different ones, how well they're connected to each other. And we'll talk more about the nature of those connections. So the systemness is really their ability to work together around some integrated task. So in this case, it would be providing really good dental care to their population of patients. So that's a relational map. So again, I want to appeal to your experience and your wisdom to think of times that you've been in a system. You've been part of a group where everybody has a specialized role, specialized knowledge, something you bring to it that nobody else brings, or you individually or your work group brings something to that task that's necessary that nobody else does. But you have to combine that together with people who bring their special expertise that nobody else has to make something happen. So you've probably had experiences of being part of a system. Could be a school organization, it could be something at work, political organization, who knows what it is. And you've probably been in some that worked really, really well, and some that you dreaded going because it was kind of discouraging because it just didn't go so well. So again, I want to go back to your experiences of systemness and ask you these questions with the same or a different partner. In this case, we can do it a couple minutes each. I'm being much more generous with the time. To share a story of an experience you've had of exemplary collaboration. Again, we won't have time to tell the whole story, but I really want you to just get to the heart of what made it work. What lessons about systemness can you draw from your experience. So a couple minutes for you to reflect on your experience, then your partner do the same, then we'll come back and harvest some of the wisdom and see what you come up with. Okay, any questions about that? All right, have fun with this. Let me ask you to switch if you haven't done so already. Switch roles within your pair. Okay, come on back, y'all. Come on back. So now, again, without going into any of the details of the story, if you could talk about the lessons learned, what did it take to make systemness work? Let's harvest some of the wisdom from your stories. We're doing qualitative research right here, right now. So what are some of the principles from your stories? What makes systemness work?
Participation.
Great. People hang back, that doesn't help anything get done. What else? Was there anything about that communication? Collective? Effective. Okay. And what made it effective? What determined effective from ineffective communication?
Psychological presence, like staying present.
Oh, cool. Not just a routine or pro forma kind of communication. Great, great. What else? You can just call these things out. Flexibility? What else?
Clear roles.
Ah, good. More?
Relationships.
And anything about those relationships? What about them made it work?
Being able to communicate from both ways.
Hmm.
Just one-sided.
Two-way, great. So people felt able to speak up. They had a voice as opposed to being oppressed, say, by hierarchy or something like that. Great, great point.
Defined expectations.
Huh? And I'm guessing that everybody knew what those expectations were, right? They're sort of public, yeah. What else?
Rules.
And what about the rules? What was it about them? Who said, yeah?
Like define some boundaries and limits when it comes to doing the job,
Uh-huh.
whatever you're supposed to do.
Boundaries and criteria. Good, okay. Any others? There were lots and lots of stories in this room.
Agreement on goals.
Cool. Was that easy to get to? Not always, right. Right, but if you don't have it, then we're working hard in completely opposite directions that cancel each other out. Yeah?
Interpersonal relationships and friendships.
And why did that matter? What did that make possible?
Friendship, either as cause or effect, seems to correlate with success.
Interesting. I could see that perhaps also contributing here to opening up the communication channels. Good, okay. Anybody else? Yes?
Diverse experiences.
Oh, yes. We will definitely come back and talk about that. And what was it about that that made a difference?
Everyone had an area to which they could contribute.
A unique contribution that they could make. Cool. That makes it meaningful when you know you're contributing meaningfully to something. Right. Yes, please.
I'm just going based on our conversation. You need a pitcher and a catcher. Each has to have a defined role, but they work together. You need both to have a unit. They need to work together.
Yeah. That's great. So let me compliment. You've sort of invented almost all of the theories that we're going to be talking about right here. And I'm sure there's much more if we had time to go through more of the stories. But this specialized role is a really good jumping off point, because everybody here is doing their job very conscientiously, and they have a unique contribution that they make that's essential, and nobody else can make it. So the issue is not how hard they're working or how much they know. It's not what's going on within their own space. It's this space between, hence the title of the talk. That's what this systemness is about. How well can we recognize, view, systematically understand that space between that allows us to share the work, to coordinate our work so that it adds up into something more. So it's really about that space between. That's what Jodi's theory is about, this theory, relational coordination. Can I tell your story? I don't want to put you on the spot here. Jodi grew up on your story. Oh, is that? Jodi grew up on a farm, and she remembers. She told me as a young girl, she had chores that she had to do, but she didn't just know what her chores were. She knew that this had to be done at a certain point so that someone else could come along and do their chore. So it's a kind of a system awareness. And it wasn't that your father stood at the blackboard at the beginning of the day and diagrammed at 8:15 you do this, and at 8:20 you do this, and telling everybody what to do. Everybody just had that larger mindfulness of the whole, that their work wasn't just their job, but it was the larger thing that they were getting done, and the interdependence between the tasks. And isn't it an interesting coincidence that that's what she goes on to study? devote her life's work to. So that theory is relational coordination. Now, I'm going to do a very fast telling of it. It's almost crazy for me to be saying this instead of you, but here we are. So this theory, relational coordination, comes from hundreds of hours observing in the airline industry, watching flight departures. So you have fuelers, you have cleaners, you have flight attendants, you have gate agents, you have luggage handlers, 16 different work groups, everybody doing their unique job, everybody having their own line of sight to this very complicated operation that's where there's time pressure, things are changing very quickly, very emergent setting. And it's all too much for everybody to report into a single supervisor who then deploys everybody. So everybody needs to maintain this kind of situational system awareness and be doing their work with the mindfulness of who else needs to know what I'm seeing and how is it that I'm doing my work that sets the other person up to make their job easier or harder, the interdependence of their tasks. So from observing all this and talking with people, interviewing with people, she developed this framework, just as you said, that for the self-coordination, the auto-coordination, not by a central supervisor, but everybody coordinating their work, it of course takes communication. And the communication has to be the right frequency. Not too much is not necessarily good, but definitely not too little. It needs to be timely, not long after something else has happened and someone can't use that information anymore. It needs to be accurate. And when unexpected things happen, when problems arise, which they always do, is the communication about solving the problem, or is it about figuring out blame? Oh, it's not my fault. Really, we can get really distracted by trying to get out of blame, and it doesn't help solve the problem at all. It actually interferes with the conversation we need. So the communication with these 4 dimensions. For that kind of communication to happen, she observed, it takes a quality of relatedness, or else that communication won't happen. And so there are three relational dimensions: shared goals, which is on your list. My goal is not to get the gas tanks filled, it's to get this plane off the gate on time. My contribution to it is making sure it has the fuel it needs. My job is getting the suitcases on. No, it's to get this plane off the gate on time. There's this apocryphal story about a janitor in NASA. Someone asked him, "What do you do?" And he says, "We're working to put a man on the moon." So people understanding their part in the larger whole and their primary identities with that larger whole. So shared goals. Shared knowledge is not each other knowing how to do each other's job. There's a lot of specialization that's necessary. Nobody can know everything. It's completely impossible. But knowing enough about what the other people are doing so that you know what do they need to know and when, so that you can coordinate your work. So knowing enough about the other people's job, that's shared knowledge. And feeling like other people know you and understand your work. And then finally, mutual respect. The pilot says, "Oh, I'm not going to move that suitcase. I'm a pilot." Or "I'm not even going to listen to you because you're just a fueler," versus everybody having a voice. See how many of these dimensions you came up with already just from this quick qualitative research that we did here. So of course these relationships and communication dimensions feed on each other. If the relationships are good and the communication gets better, the relationships get even better, and it's a virtuous spiral. But it can spiral in the other direction too. If the communication isn't so good, people get frustrated with each other, they get disrespectful, then the communication gets even more difficult and more sparse. So it's going to spiral one way or the other. The question is just to be intentional about which way you want it to spiral. The other thing about these relationships, I'm interested in what you said about friendships. It's nice when they're friendships, and that helps, but these are really about role relationships. It's about the relationships between the pilots and the gate agents. It's not, do they have to be all friends and know each other's kids' birthdays and buy each other birthday presents? It doesn't have to be personal relationships. That's a nice side effect. It's even more fun. But it's really about the respect between the roles. In hospitals, there's been a huge problem with people coming into the hospital and acquiring infections with the most dangerous bacteria on the planet. And so they're trying to mitigate against nosocomial hospital-acquired infections has been a very big priority in the healthcare system. And it turns out that it's been the people who clean the rooms, the housekeepers, who've had most of the breakthrough ideas about ways to prevent infections. And those are people who are usually, their work is kind of hidden. Their work is not visible to the big people with healthcare diplomas or things like that. And yet, when creating a situation in which they had a voice, they could speak up. That's where the breakthroughs were achieved. So it's everybody feeling like their voice matters. That's what this mutual respect, that they can speak and they will feel heard and they're not afraid to speak up. So that's a very quick overview of this framework of relational coordination. And this model of systemness. So let me give you an example of some research that Jody did. This wasn't her first study. The first study was in the airline industry, but then she went to healthcare and studied joint replacement surgery for osteoarthritis at 9 different hospitals. So Jody had by then developed a survey where people will rate people in their own work group and each of the other work groups against each one of those, for each one of those dimensions, and then roll it all up into an overall relational coordination score for the team. And then she correlated that score with a number of different performance measures, which I'll show you next. So 9 hospitals, 893 patients, measuring relational coordination among the doctors, nurses, physical therapists, social workers, and case managers. All these work groups involved in joint replacement surgery. And then these measures of quality and efficiency adjusting for patient patient factors. So here's some of the results. Look at the length of the stay. The higher the relational coordination, the lower the length of stay. 0.33 is a pretty strong correlation, and it's a negative correlation, so higher relational coordination, lower length of stay. Patient satisfaction, the higher the relational coordination within the team, the higher was the patient satisfaction of the people that team was serving. And here are some freedom from pain and mobility clinical outcomes where the correlation coefficients aren't large, but they're still statistically significant. This is the amount of pain and mobility 6 weeks after surgery. Patients are long out of the hospital. How much are they moving around? How much pain are they having? That's just stunning. And then these are some of the other factors that were in there. And you can see that for the most part, the relational coordination is a stronger predictor of these outcomes than a lot of these other things, patient age, comorbidities, pre-op status, surgical volumes, things like that. So those are very striking results. Then she combined all these into an overall performance measure that integrates all these different subcomponents of performance and plotted them against relational coordination. And here's the graph. That is a very strong correlation. You don't see straight lines all that often. Usually it takes a lot of mathematical fitting the curve, right? But here you see this strong relationship between relational coordination and the overall quality efficiency index. So that's just one example of many, many surveys that have been done. And there are many other outcomes that have been correlated with relational coordination besides the quality and safety and the efficiency and the patient satisfaction. It's also the workforce satisfaction and resilience and ability to implement new clinical processes, personal efficacy, reduced emotional exhaustion. So it's better for the patients and it's better for the workforce too. So when you can get all those different outcomes along with one thing, that's a pretty important thing to work on. So let me come up for air for a second. Say, do you have any questions about relational coordination at this point? Is it making sense? Yes. It was measured by a survey. So each of the people in each, or at least a sample, a reasonable sample of each work group would rate each other work group and their own on each of those 7 dimensions. So it'd say, how much do you, if you're a nurse, how much do the doctors share your goals for caring for these patients? How much do the nurses share your goals? How much do the social workers share your goals? And likewise for each one of the other 7 dimensions. And then you roll all the scores from all the different groups together and average them from all the different dimensions, and you come up with an overall relational coordination score for that team, and then correlate that with these different outcomes. Of course, that survey also lets you look at how each different group is being seen and interactions between different groups. There's a real depth of insight that it provides as a network measure. I'm not going to go into that in this talk, but there's a lot of there, and I would encourage you to read Jody's work. Okay, any other questions before we go on? So this is relational coordination as a measure of systemness. as describing and measuring and making visible that space between. Before that, when I would talk with organizations, be working with clients, and they'd say, how are you all working together? That question would just kind of die. It's just too broad, it's too vague, it's not safe, there's not a precedent for talking about that. But if we look at the specific dimensions of relational coordination, breaking it down into these specific things, it's much easier to talk about those things one by one. And if I had the survey, that would give me some information to use to kind of hold up a mirror back to the team and say, oh, look, here's what you all said about each other. What do you think about this? What kind of work should we do together? So it's a way of starting a collective process reflection, thinking about the space between and how we're managing it. But we'll get to that a little bit later. So that's relational coordination as a measure of, as a useful framework for further understanding this phenomenon of systemism. So let me go on to part 2 here and talk about the healthcare system and what the healthcare system is going through right now, which is so tumultuous. So historically, for many, many years, doctors would be in their own practices. Hospitals would work by themselves. There might be a diagnostic radiology center, ambulance service, home care agency, everybody doing their own thing. And they would sort of transfer patients to each other. It was sort of like a blind transfer, like you throw something over the wall and hope that someone on the other side of the wall catches it. Real fragmentation, really piecemeal work. And people often doing things without awareness of what each other was doing. So a primary care doctor might prescribe this, and then the cardiologist might prescribe that, not realizing that the primary care doctor had prescribed this, and all kinds of errors and very direct, very overt harm happened as a result of that, from that lack of systems. It's also very efficient, very inefficient. I was on vacation one summer in Maine, and my knee locked. I felt a little pop in my knee. I wasn't doing anything particularly traumatic, but my knee locked, so I had to go into the local town. And I filled out those forms that you always fill out whenever you go into a new office. It has your name and your insurance number and your occupation and your brief health review. And I filled that out to go in and see this orthopedist. And then they sent me across the street to get an x-ray. And I had to fill out exactly the same information again in the x-ray office. And so there was a lot of rework and a lot of waste there. There's a nurse who is a real expert in intensive care. She worked in the unit that she worked in. She noticed that the nurses, when they wrote their notes on every shift, would completely document all the ventilator settings. And then the respiratory therapist would come in, and they'd write the same thing down. They'd completely document all the ventilator settings. Twice, in every shift, duplicate entries from each of these specialists. And she said, what gives? Well, I don't know that they know what they're doing. It's part of my professional identity, my professional responsibility as a nurse, as a respiratory therapist to do this. So I can't delegate that. I can't let somebody else do that. I have to do that. So there's a lack of trust or awareness or coordination there, so that there was this tremendous duplication going on. Have you ever had the situation of going to 2 different care providers and being told 2 different things? When my mother-in-law was in the hospital dying, basically of autoimmune liver disease. Her body was making antibodies against her liver, and her liver was in terrible shape. And she also had a blood cancer. She had a mild kind of lymphoma. So she was getting treatment for that too. So the oncologist came in and said, well, your mother-in-law's lymphoma is cured. We'll see her in the office in a few weeks. He was looking at the blood tests, and he was technically correct about what he was saying about the blood tests, but he was not looking at the woman lying in the bed, who obviously was not going to be leaving the hospital. She was barely conscious. She could hardly move. It was just a stunning disconnect, just seeing the part and not seeing the whole. Have you ever had that kind of experience? So in lots of different ways, our work is either wasteful and not coordinated, or we're doing things in a way that's making each other harder, making each other's work harder. Without coming in, and that's our intent, but it's our lack of awareness we do that. So in my own office, my staff told me about things that I would say to patients, certain things that they could schedule transportation for a follow-up visit. I'd say, oh, just talk to Sue up front, she'll be able to schedule that for you. And in fact, she wasn't able to do that. So when I was saying that to my patients, because I didn't understand that Sue couldn't do that, I was actually putting Sue in the position of having to disappoint the patient when I had just created an expectation. So I was making her work harder. So we had a good relationship, but for status differences or whoever, maybe I'm just a hard person to talk to, she didn't feel that she could tell me about that until we actually sat down and had a conversation in our practice and did a relational coordination survey and opened up some conversations about how we were working together. Only then could I learn that. So there's a lot of feedback that we have for each other, but we may not feel the permission or the safety or the role clarity to be able to do that. Say, well, I'm not your boss, I can't say that to you, you won't hear it from me. But we have to learn how to be able to do lateral accountability, these conversations of interdependence. So anyway, the healthcare system is a mess, and the goal is to try to create systemness. Anybody here heard of the triple aim in healthcare? That's a big national movement to try to increase clinical outcomes and safety, to reduce cost, and to improve the patient's experience of care. That's the triple aim. There's no one practitioner or practice or institution that can do that by itself. It takes the whole system working together to make those kinds of outcomes happen. So there's a whole move to try to achieve that triple aim by systemness. So you have hospitals that are buying primary care practices, or employing specialists, or forming exclusive contracting relationships with home care agencies or things like that. There's a lot of corporate or structural restructuring of the system going on in pursuit of systemness. There are things like financial incentives. Anybody hear of bundled payments in Medicare? That's where traditionally the hospital gets a payment for the inpatient stay, and then the doctor gets their own separate payment for the inpatient stay. So this is an effort to combine those payments. So it's one payment that's going to go to the hospital and to the doctors together for the combined care that they produce. And then they have to figure out how they can manage that care most effectively and how they're going to share that payment. So there's some efforts for financial integration. And then there's the electronic record. That was somebody's interest in the middle there. That could be a very powerful tool for integration if people can read each other's notes and see what each other's writing. But they have to trust what each other's saying, and they have to understand each other's role and what their scope of practice is and what they can do. So there have been all these technical efforts to try to achieve systemness, but not any effort to try to work on the relational aspect, on how well people can speak with each other, on whether they have the shared goals, on whether they have enough understanding of what each other does, whether there's enough respect for people to be able to talk to each other. So you've had a structural intervention, but no relational intervention. And so it's not going very well. So there are these big, large systems, and they have some market power just by having the big name hospital or having all the hospitals in the area, and so an insurance plan wouldn't dare not have them in their plan. There's been that kind of integration, but not really moving the needle much in terms of the quality, the patient satisfaction, and cost. So because this integration is being done in such a structural, technical way, and not in a relational way, it's putting a lot more burden on the providers, and there's a terrifying level of burnout right now in the healthcare workforce. Among primary care doctors, it's approaching 50%. So just think: would you like to go to a physician who's experiencing professional burnout and depersonalization? Probably not. Again, there's research data that shows that the quality of care from burned out physicians is seriously less than from healthy physicians. But there's this epidemic of burnout, and my thesis, my sense is that a lot of it is this approach to systemness, which we really need because we're going about the systemness in a way that's not respectful. It's taking away autonomy, taking away control. In a system, by the way, you don't lose your autonomy. The idea is just instead of being independent autonomy, I'm doing whatever I want. I have this degree on my wall. I have this board certification in internal medicine or surgery or whatever. So I'm a professional, so whatever I do by definition is professional. Nobody looks over my shoulder. That's a kind of individual or independent autonomy. interdependent autonomy is what we need. So the answer to system is not to take away autonomy and from now on you just do things the way we tell you. We still want you to make independent judgments. We want you to think for yourself. We need you to do that. But you need to do it with the mindfulness of the whole, not just the mindfulness of your own doctor or nurse or social worker pie slice. So you have a kind of system awareness, and you can be doing that with that interdependent accountability, awareness of the whole. And that people can hold each other accountable, not in a mean way or a controlling way or a punishing way, but here's what I need from you, here's what I need from you, that sort of thing, to manage their interdependence. So that's the state of what's happening right now, these efforts to form integrated systems, system integration, but the way that it's being done is causing harm rather than causing true systemness. And again, the cause of that, the thing that's not being addressed is the relational core. So you can have all these structural things. You can have the shared financial incentives, the electronic record, things like that. But it comes down to this relational core that relational coordination describes. The trust, the communication, the understanding of what each other does, the respect, the shared goal. There is no technical process, whether it's in management or clinical or anywhere else, there is no technical process that does not take place in a social context, people doing it together. And the quality of those relationships affects whether you're going to get any benefit or no benefit or harm from the technical process. So it's really, these are all socio-technical processes, whether it's management processes or technical or clinical processes. So there's a relational core that needs to be tended to, and that's what's been neglected, not been attended to yet in our efforts at system transformation in healthcare. So again, any questions at this point? Yes.
Right now I'm taking calculations, and in Europe they have this system when they have magnetic cards, so you can share like medical information on it.
Yes.
So it doesn't matter what doctor you go to, as long as you have your card, all of your medical history is on that card. Why can't the same system be implemented in the healthcare in the U.S.?
It's a great question. I'm tempted to throw that open for conversation, but I think I'll never get the group again if I do that. So I think there are habits of thought. There's no good reason. There's no good reason that we can't do it. I believe every patient should be the owner of their information and have it to take with them. It just seems so obvious to me. But the things that stand in the way are 100 years of tradition about it's my medical record as the doctor, it's in my office or it's in my hospital, or I'm the one who invested in Epic or this other big information system, so I need to control it. Insurance companies were reluctant to share information with doctors who were trying to improve care because the insurance companies saw that knowledge that they had as something that was their unique, their point of, I'm missing the technical term that I need here. It was their unique resource for their place in their markets. Really, knowledge is power. Controlling that information is the source of their power. If everybody had access to it, then they wouldn't have that power anymore. So there's a lot of structural things that stand in the way of that. But it's a very good idea, and I hope we'll grow up enough to get to that stage at some point. Any other questions about this systemless view of what we're going through in healthcare right now? Good. All right, let's keep on going to part 3. So part 3 is really about implications for management. Oh, here's, I forgot my slide. It's okay. So the question here is we're thinking about what does it mean to manage something that's going to be an integrated system, to manage for systemness, which is different than the old production line mentality, the old Frederick, I'm blanking on his name, scientific management, Frederick Taylor, thank you, yes. That old-fashioned view where just the manager should be thinking and the workers should just do what they're told and their work is designed for them. What does it take to get to this new kind of system that's for management? So if we're going to have high relational coordination, think about the kinds of conversations that we need to have. First of all, we need conversations that give us a system perspective. So nobody on the team can see the whole team, can see the whole thing by themselves, can see the whole system view. I cannot have a systems view by myself. It's just absolutely impossible. You can't either. The only way that can happen is for each person to hear the perspective of each other person, not just once, but in an ongoing way. So we have to be exposed to the different perspectives, and only from synthesizing all that do we start to get the system's perspective so that I can do my work mindful of its effect on the other thing. But what happens if we try to have those conversations? As soon as I talk to somebody else, they're seeing it from a different perspective. They're going to see something different than I am. And I'm going to be tempted to think that, oh, if that's true, then I must be wrong, but I can't possibly be wrong. So I start arguing as though my life depends on it. There's some brain chemistry behind that. The opioid levels in the brain drop if you think that you're incompetent or someone is seeing you as incompetent. It's like an internal narcotic withdrawal reaction. It also activates the fight or flight part of the brain, down in the brainstem, the medulla, which we have in common with reptiles. We don't think very well from our brainstem, from our fight or flight. So the consequences, the biological consequences for how we think are very important. So how we handle that difference? Do we see it as a stumbling block and I have to overcome the other person's point of view or else I'm going to be wrong, which feels terrible? Or do we get curious and say, isn't that interesting? So I know that what I'm seeing is true, but I also know that what you're seeing is true. So how can these two seemingly different things be true at the same time? That pops us up to a higher level of understanding. So we have to have these conversations and have to have the communication skills, which you are learning thanks to the good offices of Helen Meldrum and some of the other people here, the communication skills to be able to have these conversations about difference in a way that's constructive and to be curious about it and to see that difference as the most powerful resource that we have. It's that difference that will show us a new, well, we'll come back to that in a second. So to have system perspectives, to be able to think globally even as we're acting locally, and exercise our autonomy in a way that's responsive to the whole system, not just to ourselves or our own group. So that's one kind of conversation, conversations to get a system perspective. The next one is innovation. This is where I was just starting to go. Harnessing that difference as a resource. So we're in a new situation, whether it's a new clinical situation, the patient is a particularly complicated family situation or something else, or there are new regulations coming down from Washington and we have to figure out how are we going to meet those, or a new threat in the marketplace, a new company coming in, and what are we going to do? So innovation always begins with some little bit of difference. Someone sees something differently, or someone says something without even meaning to spark a new idea in you. They say it, and you start to have a new idea, and you say, when you just said that, I had this idea. And the idea ping-pongs back and forth between you, and then you have this transformative new idea. And it happened accidentally. It happened accidentally because these two little diverse differences came in contact with each other and started something new. So we have to be able to not just have the diversity within the group, but have the comfort expressing that diversity, and also be responsive, be receptive to that difference so that we're willing to let go of the way we think about things now and considering a new way of thinking about things at all times. So we need the conversations where that difference can come together and spark new ideas which turn into innovation and adaptability. And then finally, we need to manage our interdependence. If there's something about the way that I'm doing my work that makes yours harder, you need to be able to tell me that. I'm not psychic. I won't know. I'm not doing it intentionally. Once I know about it, I'll say, hey, I'll be happy to stop doing that. Or we'll work out how can we do this thing in a way that meets both of our needs together. But if we don't talk about it, we're going to limp along in the same inefficient way. So 3 different kinds of conversations that support this relational coordination of this interdependence. Yes? Yes. Yes. If you'll bear with me, we'll come to that in 2 slides from now. Or no, in the next slide. So to be able to have these kind of conversations, there are the relational factors. Think about the relational coordination dimensions. We need trust, open-mindedness. We need the communication skills. But we also need structural factors, and that's where the incentives come in. So for example, in an academic medical center, if a physician is doing research is incentivized by the number of first authorships on articles or being the primary investigator on a grant, and that's what you get promoted for, how are you going to be working on a team? If you work on a team where someone else is the PI and you're supporting this collective effort and you're supporting their work, They're going to get points. You're not going to get any. So it really creates a situation that drives people apart. So we have all of these systems in universities and healthcare systems without necessarily being I don't think they were ever designed with that intention in mind, but they create things that lead us apart from systemness. So we have to go back and look at everything and say, does this promote our working together, or does this promote, kind of subliminally promote our working apart and working in our silos? So the reward structure is one kind of structural factor. Information systems are another kind of structural factor that we talked about. Does it make it easier for us to see each other's work? In my own practice, as we came up on the electronic record, it made my days longer, and I felt like I was a secretary typing stuff in. Not that there's anything wrong with secretaries, but I'm a very expensive secretary, and I'm not a very good one. My typing is terrible. The people much better at that than I am. And yet, so the input side of it I found very difficult. And there was a lot of just clutter in there and a lot of junk. I had to sort through a lot of stuff to find what I needed to know. But I did have a systems view that I never had before. I knew much better what happened to my patient when they were seeing a specialist. And I could just type a quick note back to that specialist, thanks for seeing them. Or when you prescribe this, don't forget that this person is on this other medicine or something like that. It just made it very easy to have these direct, quick, efficient communications. So in some ways, that was a structural support that did help me feel like I was part of a system. Other aspects of the design were very encumbering. A very important structural factor is just the venues. Do we get the people together? Do we get the right people together at the right frequency with the right agenda to be able to talk and to be able to get that systems view from each other and to be able to talk about our interdependence, to be able to manage that? When we get together in a room, how is the meeting being run? Is it the person standing and going down the agenda just telling everybody what's going to do, kind of like I'm lecturing to you despite my intention to have this be a dialogue? Or do we run the meetings in a way that we hear from everybody? Do we say, when do we make this decision? Let's go around and see what's going to be the impact for you, what's the impact for you, and value every voice and invite every voice. So there are ways of running meetings that really make them foster systemness, and there are ways of running meetings that shut it down. So just because you have everybody in the same room doesn't mean it's going to happen. It takes a further depth of understanding of meeting processes, interpersonal process, group facilitation to make that work. Then another very big structural factor has to do with how do we choose the people who are coming into our organization in the first place? Are we choosing people who like everything done exactly their way and they want to be catered to? Are we choosing people who are really good at listening to each other? Do we know how to do that kind of behavioral interviewing to be able to select people? And when we orient them to the organization, the very first part of inculcating them with our organizational culture, how are we doing that? What kind of training? And then the reward systems that we talked about. So as managers, thinking about systemness, we need to foster these relational factors, but then we also have to have the structural factors that hold them in place. If you just do the structure without the relationship, it's empty, and it can feel controlling, and it's not going to accomplish anything. If you just do the relational work, let's go do a ropes course, let's get to know each other, let's have potluck dinner or potluck lunch on Thursdays, but that doesn't then get wired into these practices, it's not going to stick. So you need the structural and the relational together. Those would be some of the management implications. So I have raced through those three areas, and you've been quiet for too long, and I've been talking for too long. So I'd like you to go back into your pairs or trios at this time, or pair up with somebody else, and just take a minute to process, to filter through what you're thinking. What has you intrigued or excited? What has you puzzled or skeptical or just outright confused? And so in these pairs or trios, formulate some questions, and then we'll come back and talk about them together. So why don't you take about 5 minutes or so just to think about where is this landing for you? And we'll have time for a group conversation.
Switch up and go over here. Yeah, and they're both very different from that.
let's come back together and let's see what's on your minds.
Yeah.
So, how is this landing for you? What possibilities do you see? What are you doubtful about? What are you confused about or want more clarification? Where is this for you? It's hard to speak up in a large group, I know.
We were talking about how when all the structural things are in place, people think, oh, well, great, we're all set then.
Now we're a system.
And now we're a system, and when it doesn't work, or it doesn't work efficiently, or the way they intended, they blame it back on structural things, not on the relational aspects.
This is still pretty invisible. The good news is, thanks to Jody and a lot of other people, there's now a very strong base of research that shows the absolute critical importance of relational factors to clinical outcomes and to organizational outcomes. So just as someone could, every patient who has a heart attack is supposed to get a medication of a type called a beta blocker. Some of you know a lot about this, to prevent future heart attacks. There's evidence-based practice that the survival is at least 20–40% better if you take a beta blocker. The likelihood of having another heart attack goes down. That's evidence-based practice. So for someone to come along and say, no, I don't really like beta blockers, or I don't feel comfortable with them, I'm not going to use them, that would not be allowed to stand. There's a standard of practice based on science. So now there's a standard of practice based on science about relationship. Why are we not as evidence-based, conscientiously evidence-based about that? The evidence is there that we really need to be stepping up to that. So to say it's touchy-feely, it makes me a little uncomfortable. Often when things make us uncomfortable, it's another way of thinking about competence. It makes me feel incompetent. Incompetence is another thing that drops the opioid levels in our brain. And so we walk a mile around anything that makes us feel incompetent. So we have to start talking about that and help people feel competent. I know that with the coursework that you have here, you have the opportunity to have these skills and to be competent in the communication and competent in understanding the interpersonal interactions and group dynamics and systems processes. So you will have a head start over people who are in management positions right now. So when it doesn't work, the other thing is expectations of control. We have this kind of clockwork. You go back to Isaac Newton and the physics from Newton, Newtonian physics or classical dynamics, which just expected you could figure out all the rules and the universe would be totally predictable and understandable. But we live in a quantum world. We live in a nonlinear world where new things are coming out of the blue and emerging all the time. And that kind of control is a ridiculous fantasy. It's a dangerous fantasy because when we expect that we should have control, or I expect that you should have control as the organizational leader, and then unexpected things happen, then that creates a lot of anxiety and blame and defensiveness, and that emotion actually gets in the way of our doing the work. So more realistic expectations about when things work or don't work, and then also taking the relational core seriously, because nothing will happen, nothing will change unless we can work on the relational core and get that right. So we have to spread the word about that, I guess. What else? What other questions or comments? I couldn't possibly have made it that clear. Yes?
I was wondering about the logistics of some sort of like national database for medical records and whether that's like politically possible.
Wow. What do you think?
I don't know about the logistics, but I doubt it's politically possible because like everyone just has so many different opinions on whether like you want your medical records to be like yours or if you want it to be like efficient and like collective. So.
Yeah, there's so many issues. Do I trust that it's private enough? Or can someone hack in there and then take data about me? I mean, I'm not any kind of celebrity, so nobody cares about my health record or so. But if I was an industry leader or maybe someone did feel threatened by me and wanted to discredit me and they'd try to go rooting around in my medical record, I don't know. So there are privacy concerns. There's issues about traditional understandings of role and hierarchy. It's my medical record, I created it. But I think perhaps if people got their own record like we were talking about before and could just take it with them, but not everybody has access to it in the whole hackable universe, maybe that would make it possible. But that's a big political change. It's a big change in professional identities and organizational incentives and strategies. Yeah, Jordan?
One thing that comes to mind when that issue comes up, one of my students is working on a extension of RC theory, basically doing RC at the stakeholder level to address some of these really tough multi-dimensional policy challenges, like shared information systems that meet the needs of different concerns, both in terms of enabling coordination while meeting privacy concerns. But why not facilitate those conversations in the same way that we facilitate conversations of interdependence around patients? So I think it's an area worth considering.
Yeah, that's good. Yes.
One thing that I don't think we've touched on a lot is how do you engender accountability in these systems so that the respiratory therapist does trust that the nurse has entered the instrumentation numbers correctly? How do you, beyond building the relationship infrastructure?
That's great. So there really need to be two kinds of accountability. So there is the technical accountability, that the procedures were followed and something was done in a safe manner. That leads into another thought about in quality improvement. There's an aphorism that every system is perfectly designed to get the results that it gets. So when an error happens, instead of beating up on that person and saying, oh, you were incompetent, you were careless, whatever, most of the time, occasionally there are people who really are careless and aren't doing the right thing. Much, much more often, the system was designed to let that error happen. We're very brilliant lateral thinkers and creative things, but when it comes to doing routine things, our minds aren't so good at that. And so to count on us getting it right all the time, remembering to do the right thing, is kind of a weak system. So we need some decision supports and information supports and checks and things to help us stay on track. So there is that kind of technical accountability, and that needs to be very clear. And we have to monitor what we're doing, and we have to be looking at our results and hold ourselves accountable for that. But there also has to be a kind of relational accountability. And that goes back to those operating principles that I showed at the very beginning. We need we need to allow each group working together to figure out for themselves, what are we going to be accountable for in terms of how we treat each other? And what will we do when we step outside those boundaries? Because we're all human. We all have bad days and good days. So we know that's going to happen from time to time. So if we have those ground rules, but somebody breaks one and nobody says anything, then it's meaningless. It's like it doesn't exist. It just makes us cynical about the ground rules. So we have to learn to say, when you just said that, ouch, some kind of code word or something for saying, I think we just had a ground rule violation. Say, when you did that, I don't think it was your intention, but it landed on me this way. Can we talk about that, or could you say it in a different way? So we need the technical accountability, but we also need behavioral accountability. And it's not just vertical, it's accountability to each other, working interdependent. So we have to learn how to talk with our peers, our colleagues, about the impact that we're having on each other. That's a new kind of accountability that we don't do very well yet. Yes?
If you build a system based on relationships as a core principle, are you building a system that's resistant to real disruptive change?
It sounds like you have a thought about that. Tell what's the thought behind your question?
So if you draw your 6 nodes, and one of those nodes is replaced, or you need a 7th node, and the IT person who never used to be part of your practice, who is now, or the person who used to keep track of the records, who probably was looking at the name of every person in your practice, who now is employed in. If relationships is your core principle, those would seem to be structures that are more resistant to change than perhaps some others.
I don't know. I think I may be misunderstanding your question, but it seems like if we're able to have a higher quality dialogue and bring our perspectives together, we will be more capable of changing, more capable of figuring out what to do and doing it together in concert, feeling less need to defend our turf because we have this shared goal. We're all after this one larger thing. The data shows that on teams where there's a higher level of relational coordination, they're better able to implement new technologies or to redesign their work processes. So they seem more change agile when there's higher relational coordination. But I may not be understanding the sense of your question. Yes, please.
Well, it's kind of about what you were just saying, how there's more flexibility to change with higher
That's very possible. That's very possible. They can text like this, and I'm still texting like that. So that's possible that it won't be as much of a barrier. Anything else? That sort of leads me to the point that I wanted to end with, because I know this time period is coming to an end. As we're thinking about this systemness, we really need you. You are the ones who are going to get us there. I think about, in the story of the Exodus, the Israelites left slavery in Egypt, and they wandered around in the desert for 40 years. And the ones who had all been slaves didn't get into the promised land. Only the ones who had been born in the freedom and wildness of the desert could go on. So as much as I am a passionate champion of relationships and of systemness, I have never worked in a system that has that kind of systemness. I don't know that experience. And for all of my best intentions, I am still rooted in a lot of professional expectations of what the doctor's role is, what my identity is, what the nurse's role is, things like that. That I may not be able to ever get very good at that. And certainly on the technical side, I am not as technically fluent as you all are. So you have fresh eyes. You'll be able to take a system perspective from the very start, because you haven't already been rooted or socialized or into the old way of doing things. And as students and as new young professionals, you can use your naive, in quotes, gaze, your innocence, to ask wicked questions that people already in the system can't ask as easily. Say, gee, I noticed that we're doing this. How come we do that? You can ask questions like that with your fresh eyes. You have license. You have a very powerful opportunity to do that you won't be able to do 10 years in. And you won't even be able to see those things because you'll be so acculturated. So your fresh eyes are an incredible asset to the system. Your lack of habituation to the old way. I also think, I really want to, I think that your curriculum here positions you in a better way than people who are in management positions right now, and then even in people in a lot of other schools, in that you have this boundary-spanning curriculum where you can learn about management science and get very proficient at that, but you can also learn about health psychology and about biology and about public policy and have a very deep personal feel and understanding for the content of the work and what it is that you're managing in a way that most people in management positions don't have a way. So that makes you boundary spanners, which is just exactly the perspective that's needed for managing in a systems world. You get a head start. And you have the opportunity to gain the kind of robust communication and relationship and interpersonal process skills that it takes to make these conversations happen. So I'm waiting for you. Keep doing what you're doing. Come along, and you'll be the ones to help us make this right. Thank you for the privilege of being here and talking with you today, and I hope this has been helpful.